Welcome back, everyone. We're going to continue with our series of regional and orthopedic anesthesia for the ABA advanced exam. And in this section, we're going to continue talking about upper extremity nerve blocks, and we're going to focus on supraclavicular blocks, infraclavicular blocks, and axillary blocks. So we discussed interscalene blocks in the previous lecture. We're going to work our way down to supraclavicular blocks, which is a really nice block to do. It's very effective for anything on the upper extremity that doesn't include the shoulder. So you can work on the elbow, forearm, hand, what have you. And you're essentially blocking at the distal trunks or proximal division level. And at this point, the brachial plexus is still pretty compact, and all it takes is a small volume of solution to produce a rapid onset of reliable blockade. Additional advantages of the block can be performed with the patient's arm in virtually any position. So if they have a fracture and they're in pain, or they're in a cast and they can't really move, this is a nice block to do. Patients essentially placed in a supine position with the head turned away from the side to be blocked, and the arm to be anesthetized should be somewhat adducted. The midpoint of the clavicle should be marked, and the posterior border of the sternocleidomastoid can be palpated. The palpating fingers can then roll over the belly of the anterior scalene muscle into the interscalene groove, where a mark can be made about 2 centimeters posterior to the point of the clavicle. So this is basically describing how you would sort of anatomically arrange the trajectory of your needle using a landmark-based technique. Okay, even though these days most anesthesiologists use ultrasound guidance. Okay. So overall, where should the needle be placed relative to the brachiocephalic pulse? So when you think about the anatomy involved, you should understand that the majority of your nerve trunks are going to be posterior to this artery. There is variability here, and some can start coursing over, but in general, they're still contained within a sheath that courses posterior to the artery. Okay. And that's what you see in this image from Miller's anesthesia. Okay, what you have down here is the first rib, and here is the brachiocephalic/subclavian artery, and all your nerve trunks are posterior to it. Okay, as they course down. And so, if you can identify the pulse, you can direct your needle posterior to that. You can use motor-evoked electrical signals to see what your response is, to verify that your needle is within vicinity of the nerves. Of course, nothing aids in your success of this block like ultrasound guidance. And so what you see here is the patient's right side with an anesthesiologist attempting to place the needle to anesthetize the brachial plexus at the level of the supraclavicular fossa. What you have here is the clavicle, and here's the first rib. Here is the artery right over here, and a bundle of nerve trunks posterior to it. So this lateral, this is medial. Okay, and this is a very straightforward block to do as you place the needle deftly between these nerve trunks to inject local anesthetic. So typically, the needle is directed in a caudad and slightly medial and posterior direction until a paresthesia or motor response is elicited, especially if you're stimulating. Otherwise, you're using ultrasound guidance to the same anatomic endpoint. Overall, if you can see the artery or feel a pulse, you generally want to course your needle in a more posterolateral direction. Now, question, what is the percent incidence of phrenic nerve blockade with a supraclavicular block? You know, it's going to be really high with interscalene, still relatively high with a supraclavicular block, somewhere in the range of 50 to 60% of the time you'll capture the phrenic nerve to some degree. And you are getting closer to the lung, and so the risk of pneumothorax is much higher with the supraclavicular block compared to interscalene. You know, somewhere in the neighborhood of between less than 1% to upwards of 5%, depending on the experience of the practitioner. So, and that's exactly what this slide explains. The onset of symptoms of pneumothorax is usually delayed, may take up to 24 hours. You know, because you're using a relatively forgiving needle, you may not, even see any clinical signs of pneumothorax, and there's probably plenty of patients that have a subclinical pneumothorax that spontaneously heals on its own without us even knowing, because we don't routinely get chest radiographs on these patients. As I said, phrenic nerve paralysis can occur about 50% of the time. Horner syndrome can also occur as well. Overall, these symptoms, resolve on their own after several hours. So the infraclavicular nerve block, another option to anesthetize a brachial plexus, and you anesthetize the brachial plexus at the level of the cords, essentially. Okay. It's no special arm positioning is required, although it's typically easier to have the patient's arm abducted and flipped up so that you can get better access to the pectoral fossa. Essentially, you place the needle about 2 centimeters below the midpoint of the inferior clavicular border, and you advance laterally to avoid the lung, and you can use a nerve stimulator to identify the plexus in this way. Of course, ultrasound guidance, again, helps identify the cords that are of interest. Okay. So intravascular injection may be increased because you are within the territory of the axillary artery, as well as venous structures that are in the trajectory of your needle plane. You can get exaggerated medial needle direction, which ultimately results in a pneumothorax. This is one of the main detracting features of you doing this block. So that's where ultrasound guidance does help you. And that's what we see here. Again, for this exam, definitely know your ultrasound imaging like the back of your hand, okay? There's no excuse for not getting these questions right because they are going to throw them at you, and you might as well know what you're looking at on the screen. Remember, on average for the ABA exam, you don't want to spend more than 60 seconds per question, and the reason is the majority of questions you're going to be able to fly through. You want to build up extra time, a buffer of time to spend even more time on the questions that sort of really make your brain hurt because they're just asking something that's a little bit of minutia that you have to think about a little bit more. With imaging, you really want to be able to look at the image and immediately know what you're staring at. And so in this patient, again, it's the right side that they're anesthetizing. This is cephalad towards the head, and this is caudad. And here is your axillary artery, as I said. And you have identified at least 3 cords here. Okay, here's the lateral cord. Okay, here's the posterior cord, and here's the medial cord. Okay, so lateral, medial, and posterior. Okay, they might ask you, they might test your knowledge of functional anatomy and how these cords ultimately terminate in the upper extremity. They might point to one of these and say, well, what is the terminal nerve resulting from this cord, for example? Okay, and so the lateral cord is always going to converge on the median nerve. Okay, the medial cord is always going to converge on the ulnar nerve, and the posterior cord is always going to converge on the radial nerve. So lateral goes to median nerve, medial goes to ulnar nerve, and posterior goes to radial nerve. Now all that becomes very relevant when you're doing an axillary block. Okay, so when you're doing an axillary block, you are decidedly very far away from the lung, so the risk of pneumothorax drops off considerably, which is the main advantage of this block. However, you can miss a peripheral nerve. Which one is most commonly missed? I'm sure you all probably know that the musculocutaneous leaves the axillary sheath before you typically, before you're in the territory where you typically do this block. Okay, and so one of the ways you test for it is to test for sensation along the lateral aspect of the forearm. So the axillary nerve blocks the brachial plexus at the level of the terminal nerves. Okay. And the musculocutaneous can often be missed with this, but since it's already left the sheath. The patient should be able to abduct the arm to be able to perform this block, because that's the only way you're going to really get access to the axillary artery, so they have to be able to do that. So which of the following correctly characterizes the location of the nerve with respect to the axillary artery? Is the median nerve superior to the artery, ulnar nerve posterior to the artery, radial nerve medial to the artery, or musculocutaneous nerve lateral to the artery? So based on everything I just described to you in going from the infraclavicular anatomy to the axillary anatomy, you should realize the median nerve is superior to the artery, okay? Because the lateral cord ultimately turns into the median nerve. And we'll have an image of that coming up in just a second. The neurovascular bundle overall at this point is multi-compartmental. So you have to sort of go after the nerves sort of individually to some degree. They're not all contained in the same sheath as they are much more proximally in the upper extremity. The nerves tend to maintain a predictable orientation of the artery, but there's quite a bit of variability though, slight variability. Median nerve is found superior to the artery, ulnar is inferior, and the radial is posterior and somewhat lateral. And like I said, the musculocutaneous has already left the sheath and lies within the substance of the coracobrachialis muscle. So you can basically direct local directly into the coracobrachialis and capture that nerve. And that's what you see here. The musculocutaneous has dived out of the sheath and is going into the coracobrachialis muscle right there. You have the axillary artery right here, and there you have your median nerve, somewhat superior, the ulnar nerve inferior, and the radial nerve posterior. So definitely remember this image from Miller's anesthesia, etch it into your brain so that you can get some of these questions correct on the exam. And with ultrasound guidance, everything is all too visible. You have the axillary artery here, and again you have the vein sitting right anterior to it. Here is the median nerve, somewhat superior. The ulnar nerve, this shows a little bit of variation. It's actually not as anterior as you would think it would be. It's a little bit more superior here. And the radial nerve is posterior. Here's the musculocutaneous that's within the coracobrachialis muscle. So the intercostal brachial nerve is a branch of T2, the T2 intercostal nerve. And you can block this with a skin wheel overlying the artery. However, adequate anesthesia for a tourniquet being used on the upper extremity can be ensured by extending the wheel 1 to 2 centimeters caudad and cephalad. A nerve injury and systemic toxicity are the most significant complications associated with the axillary block. You are sitting right on top of that artery, so you have to really watch out for aspiration of blood when you're performing this block. So that rounds it up for proximal upper extremity blocks. The third lecture here in this series will cover distal individual terminal nerve blocks. Thanks.